Hi guys, so for today's video we're going to talk about HEENT examination. So that's the examination of the head, the eyes, ears, nose, and throat in that specific order. If you'd like to learn about the theory, then that's in a separate video. But here I'm just going to discuss how we examine these areas of the body. So let's start with the head. So there's a couple of areas that we need to examine specifically. So that includes the skull, the hair, the scalp, the face, all the components of the face. So let's start with the skull. So inspection of the skull just includes like the size of the skull, any visible deformities. So in terms of size, so if it's enlarged, then that might indicate like hydrocephalus. We can then palpate the skull to feel for any like lumps, any depressions, anything that doesn't quite feel normal, any areas of tenderness. And then we move on to the inspection of the hair itself. So the hair, we need to note the quantity and distribution of hair. So if you could see thinning or hair loss, then this might suggest alopecia, which is just loss of hair in the scalp region, usually due to like an autoimmune condition that destroys the hair follicles. And if you note the opposite, like excessive hair growth, especially in women, then this might indicate hirsutism. So hirsutism is just a condition where there's excessive hair growth, especially in areas where hair doesn't usually grow in women. So like the facial region, the chin, and this could be due to many different pathologies. So for example, polycystic ovarian syndrome. We can also note the texture of the hair. So fine hair is usually seen in hypothyroidism, and coarse hair is usually seen in hyperthyroidism. And then examine the scalp after examining the hair. So we just part the hair in different sections to expose the scalp underneath, and we're looking for any redness, any scaliness, which might indicate like seborrheic dermatitis or psoriasis. If we identify any lumps on palpation, they could just be benign cysts or something more sinister. Then we can inspect the face in general. So we look for symmetry, any bruises, any ecchymosis, any deformities, any involuntary muscle movements, facial droop in case of stroke, any edema, any puffiness, and any mass or lesions. And then we move on to palpation. So specifically, we palpate for the sinuses. So we have the frontal sinus just above the eyebrows, and then the maxillary sinuses as well here. So if you're palpating for tenderness, if you're checking for tenderness of the frontal sinuses, usually we press here, just underneath the eyebrow. And for maxillary, obviously, you just it's hard. Usually I press with my thumbs, but I'm gonna use these. You press here to check if there's any tenderness there. Also, if it's indicated, we can also palpate for the temporal artery, the superficial temporal artery, which is just here. Obviously, pain and tenderness there might indicate temporal arteritis. We can also feel for the strength of the pulse. That concludes our head and face examination. So then now we move on to the eyes. So the first thing is the inspection of the external eye. Before we use any special equipment, we inspect the external eyes first. For the eyes, we look for alignment, any inward or outward deviation, any protrusion. And then we can also inspect the conjunctiva and the sclera, specifically for any color changes. So we do that by just pulling the eyelid down and ask the patient to look up, and pulling the eyelid up, the upper eyelid up, and asking the patient to look down, just to expose some of the surfaces, the areas of the eyes that we couldn't see otherwise. So you could also invert the upper eyelid to check for any foreign bodies in there. This is not done with every patient. Only if they complain of like pain in the upper eyelid, you need to check if there's any foreign material that's been stuck there. And then we move on to testing the visual acuity of the patient. So we have the Snellen chart to do this, but there's like different types of Snellen charts which should be used in different distances. So the standard ones, like when we go for standard eye tests, they are placed about 6 meters away from the patient, so that's about 20 feet. But they have like the smaller ones as well, like in smaller cards, which could be held at arm's length. So just check at which distance you need to hold the cards away from the patient. So before you start the test, if the patient usually use like lenses or glasses, then you have to ask them to wear those visual aids. This is to check that those are actually helping them, see better. And what you do is you obviously, if it's like, I'm just gonna use this. If it's, for example, the one that you just hold at arm's length, what you do is you ask the patient to hold it like this and then close one eye. I mean, they could just do this, but if they can't do that, then they could cover it with the hand, their free hand. So they could do that and ask them to read the smallest print possible. So for example, BAG, and then you test the other eye. So you ask them to close the other eye and read that the smallest line possible they could read backwards, because it might be the same line, and because they've already read that, then they could remember the letters or the numbers. So you could ask them to read it, the other way around. So for me, it will be like GAB. Just to quickly explain the result of the Snellen test. So, we would get like two numbers. So we'd get like 20/20. The top number indicates the distance away from the chart. So 20 is like 20 feet. And then the bottom number, so 20/20. So the second 20 means that that's the distance at which the normal eye could read that print. So basically, the larger the lower number is, the larger the second number is, the worse the person's vision is. And I think 20/200 is considered legally blind in the United States. Also, if you're gonna report this, so if the patient used like contact lenses or glasses, then you should put 20/20 corrected. Just to indicate that they've used visual aids like, lenses and glasses. So after testing the visual acuity of the patient, we could then move on to testing their visual fields. So there's two tests to do this. The first one is called the finger wiggle test, I think. And the second one is the kinetic red target test. With the finger wiggle test, we sit directly in front of the patient and we imagine this arbitrary 4 quadrants, and we test each eye separately. So I'll try do it with you guys. I'm gonna cover my left eye, so can you please cover your left eye as well and tell me when you could see my fingers moving. So we'll inspect all the different quadrants. So this is like the 4 quadrants, yeah? So I'm gonna test the upper quadrant first. So can you please let me know when you can see my fingers wiggling? And hopefully the patient said no. And then you test the lower quadrant. Then here. And there. And then you just repeat that with the other eye. The kinetic red eye test is kind of similar. We sit in front of the patient and we test each eye separately. We again imagine that arbitrary 4 quadrants, or if we're really worried, we can test like each hands of the clock. So there's 12 different directions, different angles that we could test. So let's do that. So usually we use a 5mm red top pin, but I don't have that. So let's just pretend this is it. So I'm sitting right in front of the patient. Can you please close your left eye and tell me when you first see the red topped pin? So I'm gonna do like the 12 hands of the clock, yeah? So there. Okay, so, and you do that with the other eye. You do the 12 hands of the clock if you see something interesting from the first test, which is the finger wiggle test, or if you're worried that the patient's visual field is severely impaired, like just to locate exactly where that impairment is. After we've tested the patient's visual acuity via the Snellen test, and we've tested their visual fields with the finger wiggle test or the kinetic red target test, we then move on to testing their extraocular muscles or their oculomotor activity. So this one is going to be tricky to demonstrate, but I'll try anyway. So what you do is you sit in front of the patient or stand in front of the patient. You could use like a pen or your finger. I'm just going to use my finger for simplicity. So, okay, what you do is you ask the patient to look straight at you, keep their head still, and only move their eyes to follow your finger. Okay, so I'm gonna be the doctor and you're gonna be my patient. So please hold your head still and just move your eyes to follow my finger. So we're just gonna make an H, okay? Good. The other side. So when we get back to the middle, we're just gonna go closer to the patient's nose. Right, so I'm gonna try do it with me. Okay. Okay, that got me dizzy. Anyway, so there, what I'm basically testing is pupillary constriction. So usually, our pupils should constrict due to near effort. So if we are trying to focus on something that's closer to us, our pupils should constrict. Also, with this test, we're looking for nystagmus, which are just like rhythmic oscillations of the eye, so they can move like side I can't they can move like side to side or up and down. So we need to note if we see nystagmus during this oculomotor test. After that, we move on to the inspection of the pupils. So we look for, the size, the symmetry again. In terms of size, the pupils can be dilated or constricted. So dilation is when the diameter of the pupils are greater than 5 mm. So any of those sizes, that's called mydriasis, or the dilation of the pupils. And miosis, the constriction, is when it's less than 3, so 3 or less. So those two. So that's called miosis. In terms of symmetry, we need to check if the patient's pupils are symmetrical or like the same size. If you see aniscoria, which is just a different pupil sizes, it's not automatically considered pathological, because I've read something like 1 in 5 people would have different size pupils. But if the patient usually has, similar pupil size, then aniscoria might indicate something like a damage in the nervous system, or damage to the eyes, or like some viral infection or something like that, that would warrant an investigation. After inspecting the size and the symmetry of the pupils, we could then move on to testing the near reaction of the pupils. So it's kind of similar to what we did during the ocular motor activity test. So we're looking for that near reaction reflex. So we could test each eye separately, or we could do them together. So we ask the patient to look at a distance and then look at your finger. Then look at a distance, then your finger. So what you should see is the constriction of the pupils as the patient attempts to focus on that near object, which is your finger. So to do this separately, what you do is just cover one eye, and then you just do the same. Can you look at, you can't really see because my pupils and my eyes are quite dark, so I wish I had like blue eyes so you could see my pupils constricting. So what you do is you ask the patient to look at a distance and then focus on your finger. Look at a distance and then your finger. And then you just repeat that with the other eye. And again, what you should see is pupillary constriction. After testing the near reflex reaction, we need to test the light reaction. So what you need is a pen light. And we're looking for two things really. We're looking for direct reflex and consensual reflex. So what happens is what should happen normally is when you shine the light onto this eye, then the pupil should constrict as a reflex action to the light. And you're also looking for the consensual reflex, which is the constriction of the pupil of the opposite eye. Unfortunately, as I have really dark eyes, you can't really see the consensual reflex, but hopefully I'll be able to demo the direct reflex. I just need to get really close to you guys so you can see. So, okay. So you ask the patient to look at a distance, or just look not directly to the light because it might be a bit uncomfortable. So I'm gonna do it now. So hopefully you saw the constriction of my pupil. Oh, sorry. Can't do it. Did you see that? So it's constricting. Yeah? Ooh. What you should have seen as well is the constriction of my left eye, but again, it's hard because I have really dark eyes. But that's what you're supposed to see. The light reaction test would actually be best observed if the room is a bit more dim. So as you can see, all the lights are on and it's proper daylight, so you didn't really see my pupils constrict that much. Plus, it's really hard for me to do this on myself when I'm looking at the camera. So you try dim the light as much as possible, and then you try do the light reaction test. So there is another special test which is really similar to what we've done previously, but this specifically tests for damage in the optic nerve. So let's pretend that this is my normal eye and this eye has damage in the optic nerve. So in dim lighting, what we do is we ask the patient to look at a distance, and then we shine the light to this normal eye for like 1 to 2 seconds. And then, so what we should have observed is the rapid constriction of both pupils. So the direct reflex and the consensual reflex in my abnormal eye. But then when we swing that to the other eye, what we should have seen is the partial dilation of both eyes. Obviously, this eye isn't doing it because it's normal, but let's presume it's abnormal, that my optic nerve in this eye is impaired. So what I should have seen when I swing the light from this eye to that eye is the partial dilation of both of my pupils. So that happens because when I swing the light from my right eye to my left eye, and this optic nerve is damaged, what that does, it reduces the afferent signal reaching this eye, and therefore reduces the efferent signals in both eyes. So what I've just described there is an afferent pupillary defect, and this is usually called the Marcus gun pupil. So the final component of the eye examination is using a specialized device called the ophthalmoscope. So we use this to look at the back of the eye, so to look at the fundus of the eye and the different structures at the back of the eye. So firstly, before we do that, the ophthalmoscope has like a light. So we can shine the light onto the patient's eye to see for a red light. So you know, like when you have that, when we had that like really old school flash cameras, and when we take pictures, you'd have like red eyes. That's actually what we're looking for in this test. So if we don't see that red eye, then this might be indicative of retinoblastoma. So that red eye is a negative test for retinoblastoma. So that's the first part of the ophthalmoscope examination. And then once you've completed that, you can then move closer to the patient and look at the back of their eye. And we follow the vasculature, and it should hopefully lead us to the optic disc. So with this, you just need to check if the optic disc is swollen. So usually it's a round structure, yellowish orange in color. And the swelling of the optic disc is called papilledema. And then you also inspect the physiological cup. You know, if it's again enlarged or swollen or bulging, then that might indicate chronic open angle glaucoma, or it can also indicate increased intracranial pressure. So that concludes our head and eye examination. In the next video, I'm going to talk about the ears, the nose, and the throat examination.